Alright guys, let's get busy talking about hormones of pregnancy. And in this video, we're going to be focusing in on a number of important hormones, and we're going to be looking specifically at their biochemical processes and the organs which they are exerted from and the organs at which they have their effect. And also some of the clinical implications and the pharmaceutical type questions. We're not going to be talking so much about the menstrual cycle in this video. We have a whole video dedicated to that, but the menstrual cycle will be incorporated to some degree. So I want to talk first about how these hormones are going to interact in the reproductively mature individual who just happens to not be pregnant. So this is going to be a patient who is undergoing menstrual cycles monthly, but is not currently pregnant. And then we're going to move into talk about how these hormones are going to be important during pregnancy and some of the specific changes to those hormones and where they're produced and the actions that those hormones are going to have. So let's go ahead after that overview and get into talking about estrogen and progesterone. So I like to label estrogen in green and I like to label progesterone in purple because progesterone starts with a P, so that really helps me. And when we're talking about estrogen, it is responsible for the follicular phase of our menstrual cycle, which I'm kind of outlining here in green. I'm going to write out follicular. And the mnemonic I like to remember for the follicular phase with estrogen is the mnemonic EFG. And this mnemonic to me stands for estrogen follicular growth. So estrogen is happening heavily in the follicular phase, and it is responsible for growth of our endometrial lining. Whereas when we're talking about progesterone, it is going to be responsible for the luteal phase of the menstrual cycle. Write out luteal phase. And essentially, progesterone is progestational. So I like to remember progesterone is going to be progestational. And that helps me remember that progesterone's job is to take the endometrial lining that estrogen grew up, and it's going to start changing that. So it's going to be things like incorporating spiral arteries and making secretions that will support the fetus, etc., etc. So one moment I want to highlight here is the element right here, and that is when our follicle is ovulated. So our egg leaves its follicle, and that follicle degenerates and turns into the corpus luteum here. And the corpus luteum is this gold structure, and that is what is responsible for producing progesterone. This happens for exactly 14 days before the corpus luteum will die, and that is what sets the set 14 days of the luteal cycle. So during this ovulation period is a critical moment where a sperm can come and it can meet this egg. And if that happens, then we are going to transition into pregnancy. And that's when we're going to start talking about beta HCG and human placental lactogen. But I just want to take a moment to talk about estrogen and progesterone first before pregnancy occurs. So let's really get into estrogen now that we've kind of talked about how these players all fit in our big picture. So estrogen is a steroid hormone, and it's going to have an intracellular receptor. And I like to talk about these receptor types in this light blue color. So let's talk about why this is important. So here is our cell, and then I'm going to make this little X to represent our estrogen, make her in blue. And then here we have an intracellular receptor, which I'm going to make this little dot. And then we're going to also have our nucleus. And the way that our steroid hormones work is that they are going to actually translocate across the nucleus and attach here to this intracellular receptor. And then that is going to go ahead and move into the nucleus where it can start exerting its effect. So these are special hormones because steroid hormones are lipid soluble. And the exam loves to ask about this because lipid soluble hormones can cross the membrane and then they're going to interact with an intracellular receptor where they're going to translate to the nucleus. And this is going to be a high yield third order question you might get about estrogen. So now that we've talked about that, let's talk about where it's made. So largely estrogen is going to be synthesized in the ovaries, and this is specifically going to be granulosa cells. So let's take a closer look here at this. So zooming into our diagram here, we have our theca cell here, which is going to be this squamous type cell, whereas we have our granulosa cell here, which is going to be a cuboidal cell. And it's going to be our theca cells that are going to take cholesterol as a precursor, and through desmolase, they're going to make androstenedione, which is an androgen. This androgen is going to transition into the granulosa cell where it's going to undergo conversion to estrone via the enzyme aromatase. And we know that aromatase is going to be important for pathologies like aromatase deficiency, which leads to masculinization of our fetus and mother. And this is because there is failure of these androgens to turn into estrogens. And so we get masculinization. That may be where a third order question comes in on exam relating to K.A.N. Finally, this estrone and estradiol undergo conversion. After conversion, they kind of exist in this nice balance, and it's our estradiol that is going to be pushed out into circulation to exert its effects. So, estradiol specifically is the type of estrogen that we get in our ovaries, and it is the most potent type. So, I like to actually make it in this dark green because to me, the dark green is like really potent, whereas our estrone is kind of like our medium potency. And then we also have estriol, which comes specifically from the placenta only, and it's the weakest form. So I'm just going to kind of highlight this light green here in our placenta to show that that's where that type of estrogen comes from. So we talked about our additional sites of synthesis, our placenta for estriol and our adipose tissue for estrone. And then we talked about our conversion of androgens into estrogens via aromatase and how this is going to be important for placental aromatase deficiency. Let's move on now to talk about what estrogen does throughout the body. So let's focus on its sexual effects first. So, in terms of sexual development, we know that estrogen is going to stimulate the production of breast tissue as well as contribute to maturation of the endometrium and the vagina. Now, there are also some important effects that happen outside of the genital region. And this is going to be our extragenital development. And this is going to be things like an increase in clotting factors, an increase in HDL accompanied by a decrease in LDL, as well as an increase in osteoclast apoptosis. And why is this important? Like, why do test writers care about this? Well, the way that they will ask you about these various effects is in screening questions for OCPs. So we know that estrogen supplementation, also known as OCPs or oral contraceptive pills, are going to be a contraceptive option for women. And we may ask women, are you a smoker or have you had a history of DVT? Or how's your bone health? And the reason why this is important is because we know that clotting factor increases are going to put you at risk for clotting. And if you already are a smoker or if you have a clotting disorder, you may be at higher risk for clots if you're on OCPs. And then what do we ask about bone health? Well, with our increased osteoclast apoptosis, we know that osteoclasts break down bone. So if we inhibit these osteoclasts, we are actually going to have healthier bone health. So you can see how test writers like to incorporate the physiology of estrogen into asking about pharmacology and options for patients in terms of contraception. Let's move on now to talking about progesterone, which is also going to be a steroid hormone. So I'm going to make our little receptor type in blue here. It's going to be an intracellular receptor. So it's going to reflect the story that we were talking about here. It's going to happen the exact same way. So progesterone is going to be synthesized in the corpus luteum as well as the placenta. It's going to be synthesized in the corpus luteum in a non-pregnant patient, where it's going to be synthesized in placenta in a pregnant patient. So our corpus luteum here, which I'm highlighting purple, is responsible for making progesterone for 14 days in the normal menstrual cycle. However, it will continue to make this progesterone if it is spurred on by beta HCG, which we will talk about a little bit later, but I just wanted to plant that seed in your mind. So we have 10 weeks of gestation, at which point the placenta will start making our progesterone. Before that, it is all up to the corpus luteum. And in terms of the sexual characteristics that we're going to get from progesterone, remember, it is progestation. So it's going to take all the work the estrogen did in terms of the follicular phase with the growing of the endometrium, and it's going to start changing that endometrium. So we're going to get things like endometrial spiral arteries forming, as well as glandular development. Additionally, we're going to get inhibition of prolactin because during a gestation, we have no need for breastfeeding. So we're going to inhibit prolactin during our pregnancy. And then additionally, we're going to have cervical mucus thickening. And this is because we don't want any other sperm getting up into our uterus. We already have fertilization, and so we do not need any more sperm. So we're going to block them out with thick cervical mucus. In terms of extragenital characteristics, we're going to have an increase in body temperature. And why an increase in body temperature? It's because we are metabolizing so much faster in preparation for our fetus. And a lot of times you'll hear about women taking their temperature throughout their menstrual cycle to kind of figure out where they are. And they are doing this because they are trying to sense if they are in an area of their menstrual cycle where progesterone is high, aka the luteal phase, and that will show in a higher temperature. It's also going to inhibit our estrogen receptors because we are working less on proliferating the endometrium and more now about maturing it and getting ready for our fetus. So, like I said, we're going to have inhibition of endometrial hyperplasia. Now that we've talked about estrogen and progesterone largely in a pre-pregnancy setting, let's talk about what happens if we get this fertilization event here that we mentioned at our ovulation time point. This is going to catalyze all of our pregnancy changes. And it's all due to this guy, beta HCG. It is so, so important. Before we talk about everything that it does, let's talk about its receptor type, which is going to be a G protein coupled receptor, which we know agonize CAMP. And this is going to be different from what we talked about with our steroid receptors. So here we have our cell, and then here we're going to have our beta HCG, which I'm going to make this little star. I'm going to make him red. And then I'm going to have this receptor here on the cell membrane. And this time, instead of transposing across the cell membrane like this, we are going to actually interact out here. This is going to be an extracellular membrane receptor. And then there's going to be a cascade of events down, down, down to the nucleus that are going to lead to cellular changes. And you can see how this is distinctly different from what we talked about here with the steroids, which went across the cell membrane and exerted their effect actually in here inside the nucleus as the chemical that they were on the outside. So there is some differential here in terms of how we like to ask these third order biochem questions. So now that we got that biochem out of the way, let's talk about what beta HCG does. Essentially, it is like the pinch hitter. It is hanging out for the first 10 weeks of pregnancy in order to make sure that things are going well until we develop a strong placenta. So it's going to maintain the corpus luteum, and this is going to lead to continued progesterone production beyond the normal 14-day period. So it's going to say, hey, corpus luteum, you need to start producing more progesterone, even though your normal 14-day timeline is up. And the corpus luteum is like, yo, I'm tired, but I got this. I'm going to keep going until the placenta is ready. So eventually our placenta down here will be responsible for making our estrogen and progesterone. But until then, we have beta HCG doing the pinch hitting. Now, there are some important diagnostic type things when it comes to beta HCG that are helpful. So really interestingly, beta HCG is going to come from our trophoblasts. Specifically, it's going to come from syncytiotrophoblastic cells. And we can measure this beta HCG starting at day 6 in the blood and then at 2 weeks in the urine. So it's really great as a diagnostic test for seeing if someone is pregnant, because people who are not pregnant do not make beta HCG because they don't have trophoblasts with syncytiotrophoblastic cells producing beta HCG. So this is a great way to tell if someone is pregnant or not. Now, there are some variations. So in a multiple pregnancy, we're going to have 2 placentas. Therefore, we're going to have 2 syncytiotrophoblasts making twice as much beta HCG. So we expect beta HCG to be higher in multiple gestation pregnancies. Now, in choriocarcinoma or molar pregnancies, we know that there is an excess of trophoblastic tissue, and therefore we're going to have more syncytiotrophoblasts cells producing more beta HCG. And so we expect to see really high levels of beta HCG in these two conditions. Now, let's talk about ectopic pregnancy and abortion. These are going to be conditions where we have low beta HCG because these pregnancies are not going as planned. And so imagine if you were a fetus trying to develop outside of the uterus and your syncytiotrophoblast is trying its best to find its ground, but it's like, this is strange territory. I don't know where I am. It is not going to do as well, and therefore it's not going to produce as much beta HCG. So in our ectopic pregnancies, in our abortions, we do not expect higher levels of beta HCG. We actually expect lower levels of beta HCG because these are examples of struggling pregnancies. Now, when it comes to our trisomies like trisomy 18, 13, and 21, there's going to be variable gene expression because we have altered number of chromosomes, and this is going to lead to altered levels of HCG. We have to memorize which ones are high and which ones are low. I went ahead and put this high yield button here because this is something that students often fail to memorize, but it comes up very, very frequently on the exam. So I wanted to make sure you guys memorize these levels of beta HCG because they can really help you get a lot of points right on exam day. Next, let's talk about human placental lactogen down here, which is going to be an important part of developing the fetus. It is an analog of human growth hormone. So I'm going to put an HGH down here to let you guys know that this is an analog of a hormone that causes growth of a human, and that's just what a fetus needs. However, this can also lead to insulin resistance, and this is going to be important because mothers can develop gestational diabetes. And questions we'll love to ask about the connection between fetal growth from human placental lactogen and the fact that mothers are going to be predisposed to developing gestational diabetes. And so that's another tie-in that they're going to ask on test day. I want to wrap up by saying that all these fluctuations in hormones throughout our normal menstrual cycle and our pregnancy cycle are going to have effects on our pituitary gland. So remember that positive feedback and negative feedback are going to be varying on the levels of estrogen and progesterone that are circulating throughout the body. And it's going to vary on the levels of FSH and LH, respectively, that are produced by these cells in response to these hormone levels. So, to wrap up with our high yield review, I want to note that estrogen and progesterone are responsible for the follicular phase and luteal phase of the menstrual cycle, respectively. And these are going to lead to various changes. Specifically, in estrogen, it's all about growth of the endometrium, whereas progesterone is all about maturation of the endometrium with things like spiral arteries and secretions. Moving on, we talked about how things change when we get the fertilization event and how beta HCG is going to step in as our pinch hitter, telling corpus luteum, hey, you need to continue making progesterone because we are expecting a pregnancy. And then that is going to occur for 10 weeks before the placenta finally grows big enough to start producing enough estrogen and enough progesterone to support the pregnancy. Some other high yield things that I want you guys to be aware of for testate are the difference in these hormones and the receptors that they have, which I highlighted in blue. Those are pretty high yield and they will sneak into questions, and those are easy points that you can memorize these. And then finally, we talked about the important diagnostic effects of beta HCG and how those are incorporated into questions and the importance of knowing high versus low levels to get questions correct. I hope you guys enjoyed this video. I'll see you on the next one.